Oh, hi everyone. Today we'll be dealing with the vascular occlusions. So we'll be starting off with the retina. So the anatomy I think it was already discussed during the tutorial. So we'll be discussing in brief in the next class. So today I'll start off with vascular occlusion. So what are the vascular occlusions? So retinal vascular occlusions, they are the serious diseases as they cause significant blindness. So what are the vessels in the retina? Similar to anywhere in the body. So the main vessels are artery and vein. So vascular occlusions means it includes arterial obstruction and venous obstruction. So first we'll be dealing with artery obstruction. So artery occlusion, again it is subclassified, that I'll be telling you. The first thing is central retinal artery occlusion. So it occurs due to obstruction at the level of lamina cribrosa, that is at the optic disc, sclera at the optic disc, which has fenestration, that is lamina cribrosa. If the obstruction occurs at that level, it can lead to central retinal artery occlusion. But if it occurs ahead, so in a branch of central retinal artery, it can lead to just a branched retinal artery occlusion. So based on the site of obstruction, the clinical presentation will vary. So, and this is the most common in case of central retinal artery occlusion. The central retinal artery occlusion is more common when compared to branched retinal artery occlusion. So it is more common in males when compared to females, and it is usually unilateral. So in very rare cases, like 1 to 2%, it is bilateral. So this is a picture. I'll be telling you about it later. So like I told you, there are two types. One is branch retinal artery occlusion and central retinal artery occlusion. So like you can see in the first picture, it is branch retinal. You can see only in one quadrant, along the one branch of retinal artery or central retinal artery, you are having the ischemia. So whereas in the other second picture, you can see complete retina is appearing pale and whitish appearance. So this is a case of central retinal artery occlusion. So there is something called central retinal artery occlusion with ciliary retinal artery sparing. So ciliary retinal artery is one of the important artery, which is a branch of choroidal circulation, which is present in the lesser percentage of population, around 15 to 20% of the population. But if it is present, and if there is a central retinal artery occlusion, and if the ciliary retinal artery will be spared, so then they can have relatively a good vision, because ciliary retinal artery supplies the papillomacular bundle. So we know macula is very important for visual acuity. So if the papillomacular bundle is spared, the patients will have relatively better vision when compared to people not having a ciliary retinal artery. So that you need to remember. So what is etiology? So the most important risk factor for artery occlusion is atherosclerosis. So since it occurs in elderly and they are more prone for atherosclerosis, so thrombus due to atherosclerosis is the most important risk factor. Other important risk factors are emboli. So it can be cholesterol emboli or fibrin emboli, so which are getting dislodged from the carotid artery or from the heart or cardiac emboli. So other relatively common risk factors are raised intraocular pressure or certain vascularitis like giant cell arteritis or polyarteritis, known as and very rarely angiospasm in case of renal migraine. All this can lead to central retinal artery occlusion, but the most important risk factors are thrombosis in case of atherosclerosis or embolism. So what are the symptoms? So like what are the causes for sudden painless loss of vision, sudden painful loss of vision, gradual painless? So one of the first thing which comes to your mind when asked about sudden painless loss of vision is vascular occlusions. It is retinal artery occlusion or retinal vein occlusion. So they present with sudden painless loss of vision. Like any ischemia occurring in the retina, it can lead to sudden painless loss of vision. They won't have any, just like MI, they won't have any. It occurs within seconds, and a patient can give history of transient vision losses in the past because of maybe small emboli getting lodged and getting dislodged by themselves. So they can give history of transient blurring of vision in the past. Transient blurring is called amaurosis fibrosis. So coming to the signs, so this is very important. So this is commonly asked in Viva. Along with the triad of RP, they ask you fundus findings in case of central retinal artery occlusion. So what are the signs? One, there'll be marked loss of vision, so it will be around hand movements or content being close to face or light perception, and on pupillary reflex examination, direct right reflex will be absent, as well as there'll be relative afferent pupillary defect if the other eye pupil other eye is normal. And on fundus examination, you can see a classical picture like the retina appears completely white, pale looking retina, and the arteries will be narrowed, and you can see the blood column in the retinal arteries. So that is called cattle tracking. Segmented blood column in the retinal vessels will be there. That is called cattle tracking. And because of the complete pale retina and even in the fovea, because of the pallor, so the underlying choriocapillaries can be visualized, and that can lead to cherry red spot. So this is another important sign. They ask about differential diagnosis of cherry red spot. In that, one is central retinal artery occlusion. Then and the optic disc will be pale. So just remember this triad: pale retina, whitish retina, arterial attenuation, segmented blood column in the arteries, that is cattle tracking, cherry red spot, and optic disc failure. So these are the important signs which we see in central retinal artery occlusion. So what are the late signs? Once the patient if the patient is coming after few weeks, few months, so the retina color would have been reverted back to normal. But other signs like arterial attenuation, optic disc pallor will remain the same, and they can have RP mottling and venous sheathing. So what is the treatment? So like in any case of a vessel obstruction, like in say example MI stroke, so there is a very less window period within which we have to re-establish the circulation. So otherwise it can lead to permanent death of the tissue. So similar way in case of retinal artery occlusion also, if we are not re-establishing the circulation within a few hours, like it can be around 4 to 6 hours. So, but various methods have been tried up to 24 hours, but ideally the prognosis is poor. If they report it after 24 hours or even after 12 hours. So what is our treatment options? So one thing is immediately we need to lower the intraocular pressure. We need to do digital compression, ocular massage. So the theory behind it is the most common etiology is emboli or thrombus. So we are trying to dislodge emboli or thrombus by doing a intermittent ocular massage. Another thing is reduce the intraocular pressure. So reduction in intraocular pressure will help in dislodging the emboli. So we can reduce the intraocular pressure either by paracentesis or by giving topical as well as oral acetazolamide, or intravenous hyperosmotic agents like mannitol or oral glycerol can be given. And another thing which can cause vasodilation is combined oxygen and carbon dioxide rebreathing into a paper bag. It can also lead to vascular dilatation, and very rarely they do Nd:YAG laser embolysis. If the emboli is visible, if it is clearly visible, they can do Nd:YAG laser embolysis through the slit lamp. So, but the prognosis is very poor. You need to remember the prognosis is very poor if the patient comes after a certain duration. So it will lead to permanent loss of vision. So it has a very less window period within which it has to be treated. So still the prognosis is variable. We can't tell, we can't predict the prognosis in case of central retinal artery occlusion. It is one of the potential blinding disease. So coming to the central vein occlusions, so retinal vein occlusion can be again subclassified similar to central retinal artery occlusion. It can be subclassified into central retinal vein occlusion, branch retinal vein occlusion. So for you, central retinal vein occlusion is sufficient. So that's the wrong slide. And so retinal vein, it is an end vein. So this occlusion leads to complete defective loss of vision. So these typically affect elderly. So all these vein occlusions most commonly they affect elderly. If they're occurring in younger patients, we need to evaluate completely for all the hypercoagulable diseases. So usually they occur in elderly after in the 6th decade or in the 7th decade. And central artery occlusion, it can be subdivided into non-ischemic and ischemic type of vein occlusions. So the risk factors, like I told you, age is one of the important risk factors. It is usually more commonly seen in elderly people above the age of 65 years. And other important risk factors in vein occlusion is hypertension. So hypertension is one of the important risk factor. And other systemic diseases like hyperlipidemia and diabetic mellitus also. They can be precipitating factors. And other ocular conditions like optic disc drusen or ischemic optic neuropathy can also predispose to vein occlusion. So if it is happening in young patients, always we need to rule out hypercoagulable status like protein C, protein S deficiency, factor V laden, or antiphospholipid antibody syndrome, or vasculitis. So that always have to be kept in mind if younger patients are presenting with vein occlusions. So I told you there are two types of central retinal vein occlusion, ischemic and non-ischemic. So we'll be discussing about that in this table. So why we need to categorize it and what is the importance? So the most common type of central retinal vein occlusion is non-ischemic type of vein occlusion. So which is almost seen in 75% of the people, whereas in very less percentage, about 25, we'll see ischemic vein occlusion. Non-ischemic, they have relatively better vision when compared to ischemic CRVO, and the fundus features, we can see lesser hemorrhages and cottonwool spots. So I'll need to tell you about the signs in case of CRVO, that I'll be telling in the next slide, but just remember, you can see lesser hemorrhages and cottonwool spots in case of non-ischemic vein occlusion, whereas in case of ischemic, you can see extensive hemorrhages, almost it is compared to a tomato splashed appearance of the fundus. So extensive hemorrhages and cottonwool spots. And on fundus and fluorescent angiography or FFA, they can see good perfusion, relatively better perfusion in case of non-ischemic, whereas in case of ischemic, we can see more non-perfusion areas. And prognosis is relatively better in case of non-ischemic. It's not like best, we can tell relatively better, and complications are lesser, whereas in case of ischemic, prognosis is poor, and sequelae like new vessel formation and new vascular glaucoma, they are more common in case of ischemic CRVO. So this is the reason we need to classify into ischemic and non-ischemic. And in case of, and when you see the relative afferent pupillary defect, in case of non-ischemic, it will be slight or sometimes it won't be there, when in case of ischemic, it will be marked. So one thing we need to check for visual acuity, we need to look for RAPD, we need to see the fundus examination, we need to get FFA done. So based on this, we can classify into ischemic and non-ischemic. The reason to classify is for the prognosis as well as for prognosis of patient. So the next is symptoms in case of CRVO. So similar to artery occlusion, they present with sudden painless loss of vision. And coming to the signs, so like I told you, in case of vein occlusion, you'll have extensive hemorrhages in the retina with cottonwool spots and venous dilatation. So since it is a vein occlusion, there will be marked venular dilatation with extensive hemorrhages, that you can see in the picture. Full retina is covered with hemorrhages and whitish exudates, which are called cottonwool spots, which are not seen in this picture. So this is a case of CRVO. So what are the investigations? So ocular investigations, To classify into ischemic and non-ischemic, we do fundus and fluorescein angiography to quantify the macular edema, which can happen in case of vein occlusions. We do OCT or optical coherence tomography. So other general profile like blood pressure, blood glucose, lipid profile, complete blood parameters, and in case of any patient, always we need to look for hypercoagulable diseases like protein C, protein S deficiency, factor V Leiden deficiency, and antiphospholipid antibody syndrome. And what are the complications in case of vein occlusions? So this is important. So it can lead to persistent macular edema or new vessel formation, retinal new vessels, or new vessels in the angles, which can again lead to neovascular glaucoma. So there is something called 90-day glaucoma, where in case of after CRU within after 90 days they are prone to development of glaucoma because of new vessels formation in the angles, which can lead to glaucoma. So it is also called 90-day glaucoma. So and one thing you need to remember, because the prognosis in case of non-ischemic is good, in case of ischemic it's poor, there are always chances 33% or 1/3% of non-ischemic people or ischemic non-ischemic CRO converting into ischemic CRO. So the patient always has to be monitored. So what is the treatment of CRO? Unlike CRAO, so we can't dislodge the emboli or clot in case of CRO. So here we need to just treat the disease as such, the complications related to the disease, like if the patient is having macular edema, if the patient is developing new vessels of the disc or new vessels elsewhere or new vessels in the angle, so we need to treat the complications. So the medical therapy, so it is classified into medical therapy as and lasers. Like medical therapy, we if there is a macular edema, we give intravitreal anti-vascular endothelial growth factor injections. So you just remember the names like ranibizumab, bevacizumab. So these are the intravitreal anti-VEGFs which will be given, and intravitreal dexamethasone and triamcinolone also have good results in case of macular edema. And we need to, if we are going for lasers, they are more commonly done previously before the invention of or before the use of this anti-VEGF, like they used to do grid laser, but right now with they are using more of intravitreal anti-vascular endothelial growth factors. So how do they help is mainly because in case of vein occlusions, it's ischemia, which is because of the ischemic retinal changes. There is overproduction of vascular endothelial growth factors, which can lead to production of new vessels, which in turn can lead to complications. So we need to reduce the VEGF production. So we are giving anti-vascular endothelial growth factors, so which will reduce new vessel formation as well as stabilize the leakage of the fluids within the barrier. So the other treatment options are which have been tried but with a very low success rate are chorioretinal anastomosis, pars plana vitrectomy, radial optic neurotomy, recombinant tissue plasminogen. All these have been tried but with a very less success rate. So if the patient develops neovascular edema, so what is the treatment? So the neovascularization develops and we have to do pan-retinal photocoagulation. So what is pan-retinal photocoagulation? So we are converting the hypoxic retina into anoxic retina in case of pan-retinal photocoagulation. We are just burning the retina. We are doing multiple burns. So approximately we are doing around 1,500 to 2,000 burns, 3,000 burns, wherein the demand for oxygen is reduced because we are converting hypoxic to anoxic retina. So why are we doing this? Why are we burning the retina and reducing the fields? Is because so when there is hypoxia, there is production of VEGFs or vascular endothelial growth factor, which in turn lead to production of new vessels. So these new vessels will again lead to, they'll be very fragile, they'll be small, lead to hemorrhages, they'll lead to traction. So they'll lead to complications. So we have to reduce the production of VEGF. So we can do this by reducing the oxygen demand. So this can happen only by burning the retina. So we are reducing the oxygen demand by burning the retina, and hence reducing the production of VEGF. So this is the principle behind using pan-retinal photocoagulation. So as well as for new vessels, we can also use anti-VEGF injection, similar to macular edema treatment. Here also we can use anti-VEGF treatment. So the prognosis in case of non-ischemic CRVO is better when compared to ischemic CRVO, and the chances of non-ischemic CRVO getting converted into ischemic CRVO is also present. In case of vein occlusions, we need to always treat the complications. There is no treatment for vein occlusion as such. So thank you.